was diazoxide unresponsive hyperinsulinism, responsive to somatostatin analog octreotide. Usually, babies who have diazoxide unresponsiveness and have persistent hyperinsulinism end up having a homozygous mutation in one of the insulin secreting channel genes, the KCNJ or ABCC8. So we thought that would be the case here, and we sent the exome analysis for the baby, and to our surprise, the results did depict a mutation or a variant in the ABCC8 gene, but this was not homozygous but was heterozygous. The commonest presentation of these babies with diazoxide unresponsive hyperinsulinism is as a result of homozygous mutations, one inherited from the mother and the other inherited from the father. So this was interesting, and what we did was we sent the parental segregation. So we sent the parental DNA for Sanger analysis of the same variant, and the father was carrying the same mutation whereas the mother wasn't carrying the mutation. Now the important clue of inheritance is if you inherit this gene from the father, you're likely to have a focal form of the disease. So hyperinsulinism, while is classified as transient, permanent, is classified as diazoxide responsive, unresponsive. Anatomically, it is classified as focal versus diffuse. And if you inherit it from both parents, you inherit a diffuse disease. And if you inherit it from the father, you develop a focal lesion in a part of the pancreas. So that was the beauty of this case. Then we subjected the baby to an 18-fluorodopa PET scan, and the scan localized the disease to the proximal part of the body of the pancreas. So this baby was then taken into the operation theater, and an endoscopic ultrasound was performed to mark the site of the lesion, which was then palpated under general anesthesia by the pediatric robotic surgeon. And once we had concurred that the scan findings, the tracer findings, the ultrasound and the digital palpation by the surgeon were all concurrent, the lesion was excised surgically under robotic guidance. And at 3 months of age, when the excision was done, the baby was deemed disease-free. The hypoglycemia never recurred. Though recurrences are reported in world literature, this baby is now close to 1.5 years old and is disease-free. So look at the difference when the inheritance of the disease is from the father. You are likely to have a focal disease. You now have 18-fluorodopa imaging in larger cities of the country which can mark the lesion. Then you take the baby up for an endoscopic ultrasound, concur the site of the lesion and get the lesion excised to offer the baby a cure. Versus when you inherit the disease in a homozygous fashion from both patients, the disease involves the entire pancreas, and we like to treat these babies with longer acting somatostatin analogs in an attempt to avoid near total pancreatectomies. So gone are the days when near total pancreatectomies were done for babies with diffuse disease. In the current era, they are managed with somatostatin analogs, and at our center we also use octreotide via the insulin pump. So you all would have heard and dealt with diabetic patients being treated with insulin via the pump. At our unit, we also treat diffuse disease patients with infusion of octreotide via the insulin pump, which helps them maintain euglycemia and avoid 4 subcutaneous injections a day in the early part of infancy. By the end of 4th or 6th month, we transit them to longer acting octreotide preparations which are administered once in 4 weeks, which help them maintain euglycemia. So a quick word is mutations in ABCC8 and KCNJ gene, these are genes which control insulin secretion in the pancreas, are the commonest causes of diazoxide unresponsive hyperinsulinism. Diffuse disease is by far still the commonest in countries like India, where consanguinity and small community breeding is common. But up to 30% of the diseases may have a focal or a multifocal nature. Now please understand, this was a simple case for the surgeon because there was only one lesion involved in the proximal part of the pancreas. There could be lesions at multiple sites in the pancreas which would require a multifocal resection. Then we do a quantitative analysis to understand whether multifocal resection would render the baby deficient in endocrine and exocrine pancreatic function. If that's the case, then we don't go ahead and excise the lesion. We manage them with somatostatin analogs, either with the pump or with the long-acting preparations. But this was, the baby was lucky. He had a single lesion in the proximal part of the body of the pancreas, which was excised, leading to the cure. So I wish to emphasize that pediatricians must be alert towards babies who do not respond to diazoxide in the NICU. These babies must always be subjected to genetic testing first. The turnaround time for yield of these mutations is close to 2 weeks. So in a couple of weeks, a good geneticist would be able to tell you the nature, the mutation in the first case, and the nature of inheritance of the mutation if you do the parental Sanger sequencing. If it's homozygous, you know the baby is going to need treatment for life. If it's heterozygous, please subject these babies to functional imaging. The commonest one available in the larger cities in the country is 18-fluorodopa PET scanning. You also have GLP-1 receptor-driven functional imaging available at certain centers in the country. And the one important feature that clinicians must look at while interpreting these reports is the standardized uptake value. Again, please understand, in nuclear medicine, everything is relative. The tracer density at the site of the disease is compared to the tracer density in the physiologic part of the organ. So you must have a ratio of 1.5:1 or more to say that yes, this is actually the site of the lesion. And I'd like to share a joke here. I'm going to talk about it with this slide. So what happens is when this tissue is excised from the pancreas, it is subjected to genetic analysis to document maternal loss of heterozygosity in the somatic tissue. So the story is not over in the operation theatre. The tissue which is resected by the surgeon is sent for genetic analysis to confirm whether he has actually excised the right tissue or has he gone in and resected the wrong tissue and left the tissue, the actual site of disease in situ. So we often reminded of this joke that a physician and a surgeon went for a walk. They saw a bird flying in the sky, and the physician was speculating whether it was an eagle or was it a falcon or another bird. And the surgeon wasn't concerned much. He just told the hunter, shoot it down and my histopathologist will analyze it what it was. So it can often happen at centers where there is no access to functional imaging. They resect the pancreatic tissue and then they ring us up saying, we've probably treated focal hyperinsulinism. Is there a way to confirm it? But because the tissue is out of the body by then we ring up our geneticist colleagues and ask them, can you document loss of maternal heterozygosity of the 15p11 region? And they say, yes, let me analyze the tissue. And it has happened once or twice that the geneticist came back and said, I don't see the maternal loss of heterozygosity in the resected tissue. And the surgeon had the heart in his mouth saying, have I not resected the right tissue? But fortunately, the clinical response is the indicator. So the babies go off octreotide within 24 hours of resection of the tissue. So if your baby is gone off octreotide, you are more likely to have had resected the correct anatomic tissue, because the sensitivity of the genetic test is close to 87%. So 13% of the times genetic tests in the histopathology sample may not yield the correct analysis. So those were the take-home messages. So diazoxide unresponsive focal hyperinsulinism due to paternally derived ABCC8 variants is amenable to surgical resection and cure. So these babies need not be on octreotide lifelong. Albeit these babies do come back with recurrences. The recurrence rate is 3 to 17% in the Indian population, but it's still 83% of the patients are cured for life and they don't need to keep monitoring their sugars at home. Homozygous disease, unfortunately, is a lifelong process, but we do have ways now. We have longer acting octreotide and lanreotide, which are somatostatin analogs, in addition to octreotide via the infusion pump, and we are now working on a newer molecule called dasiglucagon. Glucagon, as you all know, crystallizes very easily in circuits. So to obviate that, we are working on a newer molecule called dasiglucagon, which does not crystallize in tubings, and that can be infused continuously to patients via the insulin pump. So there are some new modalities, but those are meant for patients with the diffuse form of the disease. So thank you very much, ladies and gentlemen. So now from a bit of complexity of investigation, I'll move to a simple clinical case. So this is just to emphasize the importance of good clinical examination. And so we title it differently. I mean, why Dennis became Dennis. So it's just to emphasize why did a girl become a boy. And I mean, this is the scenario in the disorder of sex differentiation or the atypical genitalia clinic that we run. So this was a 3-year-old who was brought to our outpatient with complaints of an abnormal looking genitalia by the mother. So the first question that we asked the parent was, did it take you 3 years to realize that the genitalia was abnormal? And the mother was a doctor. So this was, so fortunately or unfortunately, the class of patients that I deal with are all very educated and very affluent. And it was a surprise that a baby being referred to us at the 3rd year with an apparently abnormal genitalia. So even before undressing the baby, I asked the mother that, did you ever not perceive that the genitalia was atypical? And she said, no, Dr. Kulkarni. The baby was well inspected, well seen at delivery, and the genitalia looked all right. And we were assured that it is an unambiguous female, and or rather she said we never raised the topic of atypical genitalia. It's only in the last 6 months that I'm perceiving the genitalia to be looking a bit ambiguous. So we looked back into the history. There was no consanguinity. It was an uneventful pregnancy and a section delivery, but nothing remarkable in the history. And the mother was very, very insistent that she never perceived any genital ambiguity at birth. And there was no major history like a salt wasting crisis or a dehydration for us to get alerted towards a salt wasting type of congenital adrenal hyperplasia. So all along, this child was being reared as an unambiguous female. So in the 3rd year, the mother started to notice progressive enlargement of the clitoris, and she started to find the labia looking a bit more prominent. On examination, the clitoris almost looked like a phallic structure. This is where we started to doubt the level of understanding or the intent of the mother, and we said a 2.2 centimeter phallus can't develop overnight. It could have taken a few weeks or a month to develop. And on very careful palpation, there was something palpable in one of the labioscrotal folds. And if you can palpate something in the labioscrotal fold of an apparent female who has been referred to you, it can't be the ovary. The ovary is the queen. It never descends down into the inguinal canal. It has to be the testes or the ovotestes. So men are easy, you know, they would walk a mile. Women would never walk a mile. This is a simple take-home message that if you're able to run your thumb from the inguinal region on the labial folds of an apparent girl and you palpate a tissue, that tissue is more likely to be a testicle, or it could be a mixed gonad like an ovotestes. So that started to alert us that, yeah, here we have a case on, and we sent the child to an ultrasound immediately. And the sonologist called back saying, I'm able to see 2 hypoechoic structures in both the inguinal canal, and there are no Mullerian structures seen. So there was no uterus, and both the gonads sonologically looked like a testis. So I said it looks more like a testis, and I don't see any Mullerian structures. So for all practical purposes, I'm going to write down that I see bilateral undescended testes with no Mullerian structure. So he said fine. Then, so we sent the karyotype. What we usually do in the DSD clinic is we do FISH for an SRY region because the result turnaround is much faster. You get a result on the 3rd day, whereas a conventional karyotype takes about 11 to 14 days. So we obviously do karyotype in all patients, but in this patient we went ahead and did the FISH. And the geneticist rang us up saying, yes, there is a Y chromosome here. So we were now certain that this is a 46XY disorder of sex development. The next thing we wanted to do was to differentiate whether this was some form of androgen insensitivity, which was partial in nature, because of which the gonad looked like a feminine one and the child was reared like a female, or was this some form of enzyme deficiency or testosterone biosynthetic defect or a conversion defect, or then were we dealing with mixed gonad like an over-testicular DSD. So we had 3 clinical differential diagnoses. Though the length of the phallus made us think that it could be less likely an androgen insensitive individual, because 2.2 centimeters of a phallus suggests that there is some response to the androgen by the body. So we went ahead and performed the basal gonadotropins and then an HCG stimulation test. So what we do is flog the gonad with human chorionic gonadotropin for 3 successive days and estimate the testosterone, estradiol and dihydrotestosterone on the 4th day. Now estradiol is only included when you are suspecting a mixed gonad or over-testicular DSD. Otherwise it's usually testosterone precursors, because if it's a testosterone synthesis defect, the level of testosterone would be low, while those of the precursors are going to be high. And lastly, we look at the dihydrotestosterone level, which is the final effector of androgen on the genitalia. So the length of the penis, the hair on the body, especially the androgen dependent sites, and the baldness later is all regulated by dihydrotestosterone. So we looked at these, and as anticipated, by then it was looking like a child with 5-alpha reductase deficiency, and as anticipated we saw normal testosterone levels on stimulation but undetectable dihydrotestosterone levels. So the case was cracked that the baby was producing enough androgen, but it was not getting converted to its final effector form, the dihydrotestosterone, and hence the baby had a clitoris-like looking genitalia at birth, which was passed off as an unambiguous female. Now the story started. We sent the genetic studies, and the exome analysis yielded a homozygous mutation in the 5-alpha reductase 2 gene, which is the commonest site for a major degree hypospadias leading to an atypical genitalia. Parents were counseled regarding the nature of the condition and the natural course of this condition. Now, the strange thing about this condition, there are 2 or rather 3 conditions in disorders of sex development where the doctor is allowed to play God and dictate the sex of rearing of the child. In all other indications, you ought to respect the wish of the child and of the parents to advocate and assign the sex of rearing. So one of them where doctor is allowed to play God is 5-alpha reductase 2 deficiency. This is because at puberty, irrespective of what sex you have assigned to the baby, these children are going to masculinize, because the 5-alpha reductase isomer 1 takes over to cover up the deficiency and virilizes the individual. So if you rear these children as girls, they're going to come back at 13 years asking you to make them a boy, because they would have started to grow mustaches, beard, a large penis, and they have extreme desire to be manly. So this child was luckily caught in the 3rd year. So we told the parents though had reared the child as a female, their initial reaction was, what do we go back and tell the society? So I said, don't bother about the society, just be happy that God has blessed you with a boy and he's going to be a healthy boy. And the strange thing about this disorder of sex development is these children are universally potent and fertile. So patients with this form of disorder of sex development are universally fertile. They are not infertile like the other unfortunate children with androgen insensitivity or other forms of testosterone biosynthetic defect. So that was reassuring to the parents. We started applying 2% dihydrotestosterone locally, and in a matter of 6 months, the child had a normal sized penis. Our reconstructive surgeons corrected the hypospadias and brought down the testicles into and made a small hypoplastic looking scrotal sac. And with progressive use of dihydrotestosterone, in addition to increase in the penile length and girth, the rugosity of the scrotal sac also improves. So the entire genital complex starts to look masculine. So now at the end of a year or so, the genitalia look almost unambiguous masculine. We are reasonably certain that this boy now, and that's why I say why Dennis became Dennis. So now Dennis is going to masculinize very well at puberty. He's going to be as potent as any other man can be and as fertile as any other man could be. So the natural course of the condition from an infertile female, because at 13 he would anyways have come back with a significant gender identity disorder, with an element of dysphoria, and at that time it is imperative at larger centers to make these patients undergo gender role play. So they are made to live the life of the prospective sex of assignment for 30 days. Say for example, if the girl is being, if the individual is being reared as a girl and wishes to be a boy, they have to be sent to male toilets, and in Bombay they are made to board local trains in the gents compartment, and then the degree of dysphoria is assessed by the psychologist and certified if a sex reversal surgery and hormone replacement of the contralateral variety is advocated or not. So all of this was avoided because at 3 the gender identity is just being formed and we caught it in the nick of time. The other condition where doctors could play God is 21 hydroxylase deficiency, the CAH, in a 46XX individual. Again, these females are universally fertile, but the problem is if they have been imprinted with androgen very severely in fetal life, they have a significant degree of gender dysphoria if you rear them as females. So an XX individual coming to you with PREDA4, PREDA5 virilization, you control the CAH very well, do a reconstructive genital surgery, make them as feminine as one could be, but they are a little unhappy in adult life, and throughout childhood they would depict tomboyish traits. And this is the reason why Tamil Nadu does not allow genital reconstruction surgery prior to the age of 11 or 13. Whereas in other states, parents try to override the wishes of the child and there is no legislation, but Tamil Nadu is very particular, and they've especially CAH 21 hydroxylase deficiency with PREDA 4 and 5. So there is a grading offered to the virilization of the genitalia. If you're grade 1, 2, 3, you're not as fetally imprinted with the masculine hormone. The 17-OHP is a masculine precursor. So you have a chance of being imprinted back as a female if your karyotype is XX. So the doctor is allowed to play God and say you're a girl. The psychologist is allowed to counsel the child that you're a girl, and the parents are allowed to rear the child as a girl. But if you're PREDA 4 and 5 and you presented late with a large phallus, some states in India now are of the opinion that let the child decide what he or she would want to live as. But if they want to live as a male, the phallus can be constructed, but there are no testicles in situ, and these individuals are infertile. But if you rear them as a female, they are universally fertile, but they have a bit of gender dysphoria. They are a bit unhappy in their marital lives. So the choice has to be made by the individual, by the parent, and the doctor has to quietly respect the choice, because we would not want to take the responsibility of things going wrong later in life. But minor degree virilization, play God and rear the child as a female. 5-alpha reductase, play God and rear the child as a male. Complete androgen insensitivity, play God, remove the testicles, rear the individual as a female. And because these individuals have extreme insensitivity to androgens, they are phenotypically more feminine than the women without a disorder of sex development. So these are 3 conditions where you can play God and decide the sex of rearing. Others, there are a host of factors like the natural course of the disease, the ease or difficulty of hormone replacement, the chances of malignancy in a gonad left in situ, the fertility potential, the gender identity, gender dysphoria. All of these are, and most importantly, the wishes of the child and the parent, which are taken into account before a decision on sex or rearing is allocated. So, yeah, so this was just to emphasize that it's the final form of enzyme conversion defect. It can easily be overridden by commercially available dihydrotestosterone cream. And if someone gets up and asks, what if the penis does not increase in size with 2%? Increase the strength of the cream of dihydrotestosterone. So you have it in 2%, 3.5% and 5%. And there hasn't been a case reported where 5% or lesser has not worked in a patient with 5-alpha reductase deficiency. But the diagnosis must be confirmed biochemically and genetically. You can't make an empiric diagnosis and use dihydrotestosterone cream. So this is just a representative picture. And to emphasize again, at puberty, the penis enlarges in size, testes almost descend into the unfused labioscrotal folds, the voice deepens, the beard starts growing. Now these are descriptive words from a British textbook taken from an era before genetics came into vogue. So this is how British clinicians described the condition, that they reared the child as a girl, and at 13 she came back with all of this, and I had to reassign the sex of rearing at puberty. So thank you very much, ladies and gentlemen.
Thank you so much for sharing your knowledge with us, sir. I would now like to call Dr. Jansi to take over the stage.
Good afternoon, everybody. I'm here to distract you from a long information hole you've gotten to now. For us, we are all pediatricians with an inner hidden child, always awaiting to waken up. So, I'm here to play a game to invoke all the inner children, and to क्योंकि break तो बनता है ना. Okay, so the game goes this way. Because it's an endocrine CME, we have hidden the endocrine terminologies in these pictures. All you have to do is identify these terminologies. The first one, the first one is an example. DEXA, the DEXA of Texolat, Meta, and Coswell. Dexamethasone. So this is how the game goes. Okay, we'll go ahead with the next game. Don't become the kids. Please raise a hand and answer the question. Any guesses? Reshma ma'am, you get a 5 star with 3 stars. The next game, the next fight. Suman ma'am was louder. Let's deviate from the students of STM.
Keep the chocolates there only.
The last slide. Louder. There's a tie between Purnima ma'am and another person. Okay. So this game remains to be continued. Break ke baad. Thank you.
I now welcome Dr. Kumar Andri sir for the next one.
But still I'm not very convinced that all are awake. Can you please stand up for a while? Turn to your right. Your left. Just rub your hands. Just wipe your faces. You can feel a little refreshed. Yes. It's always difficult to come in after Virat Kohli or now Sachin Tendulkar earlier gets out. It's a tough job to do. Let me see how much I can do. So I've been assigned to speak on resistant rickets. We have postgraduates here. Yeah.
That section is all post.
Which is a PG lot.
Our last.
Yeah, fine. So we'll have some question and answers and interactive kind of a thing, so that we'll learn better. So these are two words we keep on using, right? Rickets and osteomalacia. Anybody? What's rickets? What's osteomalacia? Great. And rickets is harmonic. Excellent. Excellent. Very nice. So rickets is there is deficit mineralization at the growth rate
leading to architectural disruptions. Okay, whereas osteomalacia is impaired mineralization of the bone matrix. So this is bone matrix problem. Whereas rickets, it happens at growth plate, leading to disruption and different disfigurements of the bone. Okay, this is the basic beginning. Before going to resistant rickets, because there are many postgraduates, some are in first year also, I just thought we'll have some basics of rickets first. So rickets and osteomalacia both can happen when the growth plates are open. Okay, when this fuses, it's only osteomalacia, no more rickets. Okay, that's why if a child is suffering from PM, we don't see florid ricket features, because we need to have a growing bone to see the classical features of widening and other things of rickets. You understood? This is an important point, that we need to have an open growth plate and active bone which is growing to manifest features of rickets. So then what causes rickets? We have two classifications. This is a textbook classification, any textbook will give you this. One side we have calciopenic rickets, on the other hand we have phosphopenic rickets. What is calciopenic rickets? When we measure calcium, calcium is low or sometimes normal also. When we measure phosphorus, phosphorus is low, this is phosphopenic rickets. Okay. And this is more common. What are the common features, common causes? We have nutritional vitamin D deficiency, calcium deficiencies, or abnormalities in the vitamin D metabolism. And I'll go through that metabolism once shortly. Then some issues with the kidney, where there is loss, and we have liver diseases, and final lot is vitamin D resistant rickets, where there is a problem with the metabolism of vitamin D. Okay, in liver and kidney and in end organ receptor issues. So just remember this, we'll be all of them individually. We have phosphopenic rickets, where there is the problem is low phosphate primarily. Okay, here it is low calcium primarily or low vitamin D primarily. Here phosphopenic rickets is mainly low phosphate, and these are some of the causes. So what happens when there is vitamin D deficiency? Okay, what is the ultimate cause of rickets, all these features that we see is, when vitamin D is not maintained, what happens to the calcium levels? They drop down. Alright. When there is hypocalcemia, what happens to the parathyroid axis? It gets activated. Low calcium, it activates parathyroid hormone. All of you know, right? There are parathyroid glands which secrete parathyroid hormone in response to hypocalcemia. This parathyroid hormone will go and act on bone and more of bone resorption, and this leads to calcium infusion in the serum, so that normal calcium is maintained. This is parathyroid metabolism. Should I repeat for postgraduates? Low calcium stimulates parathyroid hormone. Parathormone acts on the bone, causes release in the resorption of the bone and releasing calcium and maintains normal calcium levels. Otherwise, if there is hypocalcemia, what happens? Child may die also. Okay, so this is a protective mechanism which happens in case of hypocalcemia. It could be primary hypocalcemia also, or it could be secondary to vitamin D deficiency. But as a byproduct or as a side effect of this hyperparathyroid, what happens is this hyperparathyroid has got phosphate uric effects. Parathyroid hormone, what it does? It goes and acts on the kidneys and cause phosphate urea, जो नहीं होना चाहिए. We can't control it. Okay. PTH rise is in response to low calcium and rise in calcium. This is what was intended by the nature. But there is a side effect of this PTH rise which causes calcium normalcy and normal life. The side effect is, or the cost is, this PTH acts on the renal tubules to cause phosphate excretion. Getting the point? So there will be phosphate urea as a side effect of increased PTH. So this increased PTH causes phosphate urea and increase in the alkaline phosphates. So this will cause osteomalacia and rickets. How? Now you know one point, that vitamin D deficiency, how it causes hypophosphatemia. Okay. So what ultimately causes rickets is, this hypophosphatemia is what causes the florid features or bony deformities what we see. So how? How is, because of the low calcium, there is impaired mineralization, we know, and impaired osteoid formation. But phosphate is the one which is required for the apoptosis of the chondrocytes. When there is bone formation, we know in pathology there is something called as apoptosis. What is apoptosis? Programmed cell death. Okay, otherwise there will be excessive proliferation. So the phosphate ion is the one which is required for this programmed cell death and proper molding of the bone. Okay, so what normally happens is when there is normal phosphate, there will be apoptosis of the hypertrophied chondrocytes by phosphate ion. If in rickets, because of the low phosphate, this apoptosis that had to happen, it doesn't happen. That's why we see all the bony features of widening, because the chondrocytes start getting accumulated, which are not removed, and there is no mineralization. So this is a very soft bone. So it starts bending also. Understood the basics of rickets? So this is what is cause for bony deformities: role of phosphate, role of parathyroid, role of hypocalcemia, and role of vitamin D in rickets. Clear till now? Are you with me? Yeah. Next. We know that bone formation is this equilibrium between calcium phosphate and the bone matrix formation. So when there is I'm just explaining the same thing. The PTH gets activated, there is phosphaturia. So what are the sources of calcium and vitamin D? One is diet. So in the diet, when we consume this glycerol, this is converted into calciferol by exposure of the sunlight. Yeah, this calciferol is converted into 25-hydroxy vitamin D by 25-hydroxylase enzyme in liver. So this is the second product. From calciferol, it is converted into 25-hydroxy vitamin D by 25-hydroxylase enzyme in liver. And this is converted into 125-dihydroxy vitamin D, where by 125-hydroxylase enzyme. And this is the active metabolite which acts on the receptors. Sorry. So which acts on the receptors and executes all the actions. So what happens is when there is dietary deficiency of either of them, what are the different levels at which we can have pathology? So till now we discussed physiology. Now at different levels where we can have is, one, there could be dietary deficiency of vitamin D or calcium. Second, the child is consuming enough of vitamin D, but there is a malabsorption. So second level could be at the gut level, malabsorption. Third is, child is consuming enough, but there is no sunlight exposure for conversion. So by now we don't believe in this system at all. All of the children have to be supplemented is what we believe, but still, because of the lack of sunlight, there is no conversion. And at the third level is, this is a very rare cause of chronic liver disease, which is causing a vitamin deficiency. These are very important things. Once this is converted into 25-hydroxy vitamin D, this needs to be converted into 125-dihydroxy vitamin D by the enzyme 25-hydroxylase deficiency. There are children who lack this enzyme of 125-hydroxylase deficiency, 125-hydroxylase enzyme. This causes what is called as vitamin D dependent type 1 rickets. Understanding? So, one, dietary deficiency. Directly coming to second point, this is vitamin D deficit rickets. This is vitamin D dependent rickets type 1, when there is deficiency in this enzyme, or if there is a chronic renal failure, if child is having kidney failure, renal failure, this enzyme would not act, so these children will have rickets. Understood? So either in deficiency of 125-hydroxylase enzyme, or inability of the kidney to convert this 25-hydroxylase into 125-hydroxy vitamin D into 125-hydroxy vitamin D due to renal failure. These are the two conditions which come into action here, two pathologies. So one, vitamin D deficiency. Number two, VDDR type 1. Number three, chronic renal failure can cause rickets. Or there is everything is fine till here, but the active metabolite that has been formed, it is not able to act at the receptors, which is called as vitamin D VDDR type 2, that is vitamin D resistant rickets. Understood? This is what I said in the first classification or causes of the rickets. These are all calciopenic rickets in that box, if you remember. Coming to this side, independent of calcium, independent of vitamin D, there are certain diseases where there is phosphaturia, phosphate excretion, which causes rickets. Okay, phosphate is needed, right? If there is hypophosphatemia, there will be bone disruption. So these diseases are these two: phosphate, that is your hypophosphatemic rickets, and fine polycythemia, where there will be excess of phosphate excretion independent of PTH and independent of calcium. Clear? Okay, this is phosphopenic. So this column, it constitutes calciopenic rickets, and this part, it constitutes phosphopenic rickets. Are you with me? Yeah. Rickets. So calciopenic, I said vitamin D deficiency, VDDR type 1, VDDR type 2, this is receptor defect, and chronic renal failure. How does calciopenic rickets present? It presents very early onset. There could be tetanic, there could be low calcium, and there will be high PTH invariably. Clear? Calciopenic. On the other hand, we have acidosis problems also, like proximal tubular acidosis and distal tubular acidosis. How do they present? They present with this polyuria, acidotic breathing, nephrocalcinosis, and failure to thrive. Whereas phosphopenic rickets, these children are just asymptomatic. Okay, only most commonly involved are more of lower limb involvement. What is the key here? Normal calcium and normal parathyroid. Because that component, that axis just we went through is normal and intact. Normal calcium, normal PTH, only phosphate excretion. So this is, these children will be having normal calcium, normal PTH, no symptoms, but more of a lower limb involvement is possible. Possibly. Can I get some water, please? Let us discuss some cases. Thanks. Thank you. So let us discuss some cases. It's a 3-year-old boy. He received good amount of vitamin D. He is already diagnosed to have rickets. No ambiguity in the diagnosis. After treatment, there is still bone pain, and you can see alkaline phosphatase is not coming down, and PTH is still on the higher normal side. Calcium is normal. Should we label this child as resistant rickets? This X-ray helps. What is this? Zone of calcification. So this is not resistant rickets. It is a normal response. The bone age and rise in ALP, even after 6 weeks of therapy, is a normal response to the treatment in rickets. What is reassuring is this zone of calcification. So this is not resistant rickets. We don't have to apply the resistant rickets approach here. Okay? This is not resistant rickets. 4-year-old boy. He also has been diagnosed to have rickets unambiguously. Okay? No problem with the diagnosis. But he had received 5 ml of osteocalcium, the syrup that we give, and after 30 days, there is no line of healing. Okay? So is this resistant rickets? Anybody? Loud, loud, loud. Exactly. So this is inadequate treatment. Okay, just calcium, osteocalcium contains hardly any vitamin D. So this child required vitamin D. So when you don't supplement properly, so you don't expect them to be resistant. You don't expect them to be normal or respond well. So it was resistant. It was inadequate therapy. Can you see this girl? 7-year-old girl, polyuria. Okay, short stature. Weight is also less. This child is failing to thrive. Should we label her as resistant? Yes. So this child had a renal failure, creatinine of 2.5, polyuria, failure to thrive. These are some of the pointers towards resistant rickets which needs extensive evaluation. Okay, this is chronic renal failure. Now you know how renal failure causes rickets. Okay. Then, so 14-year-old boy loaded with tons of vitamin D, He has got normal growth. Lower limb is involved more. Anybody can shout the answer? Phosphate. Yes. So is it resistant rickets? No. This was this was more of phosphate problems. Okay. Normal creatinine, normal calcium, phosphorus is low, ALP is high, and vitamin D is normal, PTH is normal. Can you apply that algorithm here? Yes. So what we do is we calculate something called as tubular maximum phosphate. Okay, where there is no reabsorption. So how do we calculate? I have sent you an article in the WhatsApp group. Okay, you can go through that. All of you are in that group, right? CME. It's a calculations that need to be made. Okay. No, don't look at it now. Now you just understand that the tubular maximum is low. It means that how do we diagnose hypophosphatemic rickets? One is low phosphorus, and second is this child has to lose lot of phosphate in the urine. Are you with me? Yes, sir. So how do we know whether this child is losing or not? Is by this test. Okay? So this is low. This child is not reabsorbing phosphate. So this is called as hypophosphatemic rickets. Clear? These children need almost a lifelong treatment with phosphate preparations. 12-year-old child had multiple fractures, polyuria, muscle weakness. You can see the fracture there. This child is failing to thrive. Is it refractory rickets? The pointer here is multiple fractures, pathological fractures. Yes. So this child had acidosis and there is a renal calculi. This is the case of renal tubular acidosis. 3 months old, very early onset. Okay. Calcium is low. Phosphate is also low. Rickets. So resistant rickets. Yes. Early onset. Convulsions. Okay. This child had normal 25 hydroxyvitamin D. Okay. So this is VDDR type 1. Sorry, this 125 hydroxylase value is missing. So what happens in this children is 25 hydroxyvitamin D is normal, but because of the enzyme deficiency, that is 125 hydroxylase enzyme deficiency, this 25 hydroxyvitamin D is not converted into 125 hydroxyvitamin. So here what happens is 25 hydroxy is normal with low 125 dihydroxyvitamin. Are you with me? So this child had low 125 dihydroxyvitamin D, normal 25 vitamin D. So this is VDDR type 1. Okay. Anybody can shout the diagnosis looking at her hair? Type 2. This is VDDR type 2. You can see the limb deformity. This child is on calcium infusion since early life. Similar type of issues in the other cousins. Alopecia totalis. This is poor dentition. You can see the X-ray. What happens in type 2? Calcium is low, ALP is elevated, PTH is very high because very severe hypocalcemia, very high PTH, 25 hydroxyvitamin D will be normal and 125 dihydroxyvitamin D is sky high. What is happening here? This 125 dihydroxyvitamin D, which is active metabolite, is not able to act on the receptor. Okay, so much resistance at the receptor. It is going on elevated, increasing and increasing, but still there is no response. So how do we diagnose type 2 vitamin D DR? Is normal 25 hydroxylase vitamin, 25 dihydroxy, normal 25 hydroxyvitamin D and elevated 125 dihydroxyvitamin. This is VDDR type. So how do we treat? You had a quiz, right? Calcitriol, that is active form of vitamin D, and calcium supplementation. VDDR type 2 is very difficult to treat with whiteboard needles. Sometimes those jugular venous infusions. They need continuous vitamin D infusion, calcium infusion for life. So when do we think refractory? We think refractory when there are these points. One, if there is polyuria, if the child is failing to thrive, if there are pathological fractures, or if there is symptomatic hypocalcemia. So vitamin D deficiency do not present with such things usually. So these are the signs and symptoms when we think of resistant rickets. So how do we approach this? We have a child comes to you with low vitamin D. You have done a vitamin D value, low vitamin D with hypocalcemia. Okay, so how do we treat hypocalcemia? It could be symptomatic also. So we need to immediately raise the calcium level. So we need to give active form of vitamin D, that is 125 dihydroxyvitamin D along with calcium in order to prevent arrhythmias and other complications associated with hypocalcemia. So normal calcium, continue with vitamin D. This second point is vitamin D deficiency, low vitamin D with rickets. There is rickets. Then ask these questions. Is there any polyuria? Does this child have seizures? Are there any fractures? Or is there any growth failure? These are some of the pointers which makes us think resistant rickets. So then don't label immediately these children to have resistant rickets. All children, even when they have these things, they have to receive the normal course of vitamin D and calcium. Unless until there are life-threatening hypocalcemic complications like arrhythmias or convulsions, where we need to give calcitriol as well as IV calcium to pull the child out of the emergency, they need to follow the same vitamin D and calcium therapy. After 6 weeks, take an X-ray. If there is no response, then label them as refractory. If there is response, continue treatment. Okay? So these symptoms should make us think resistance, but not label them as resistant immediately. Okay? Then there is low vitamin D, but no rickets and normal alkaline phosphatase. So give only vitamin D. Okay? After 6 weeks, repeat vitamin D. If it is more than 20, continue this prophylactic dose of 400. If vitamin D is still less than 20, we can continue 1000. So what is the minimum workup required in a, I can leave this PPT here only. It's there. Yeah. Take a click soon. So what is the minimum workup required? Calcium, phosphorus, alkaline phosphatase. So many a time in NICUs and in PICUs in wards, I see people asking only calciums. So asking isolated calcium is useless. It doesn't take us anywhere. So whenever you are pricking a child for calcium, minimum these three: calcium, phosphorus and AL. Unless until it's an emergency, always take fasting sample, because phosphorus is a ubiquitous molecule. In anything you eat or drink, there is phosphorus, and phosphorus which is consumed, it alters the serum values. Before 10 AM, fasting sample, calcium, phosphorus and ALP, which it will make sense. Isolated low calcium doesn't make sense, it doesn't take us anywhere. Okay? So then creatinine, do you agree? If there is any issue in this, then we need to know whether renal functions are normal or not. PTH, whether there is secondary hyperparathyroidism or not, and blood gas. For resistant rickets, this is the minimum workup. If there is acidosis, we move towards renal tubular acidosis. If PTH is high, that helps us rule out hypophosphatemic rickets. If creatinine is high, it takes us towards renal osteodystrophy. If this is the calcium phosphorus ALP, will first guide us which way to go. Okay? Then, so these are some of the key pointers. If there is phosphate is high, only in this case, child comes with rickets with high phosphate value. Where does that happen? Only chronic renal failure. Why? Because phosphate is excreted from where? It is excreted from the kidney, and kidney is not working. So rickets, osteodystrophy with high phosphorus is invariably renal failure. So PTH is always normal in hypophosphatemic rickets and renal tubular acidosis. Clear? Yeah. So urinary calcium will be high in renal tubular acidosis. Okay? Now, this is an important slide. I want your attention. Once we label them as resistant rickets, how do we approach? When do we label children to be resistant, to have resistant rickets? One, with symptoms, or if there is no response after 6 weeks adequate treatment of vitamin D and calcium. Number 1. Number 2, still there are few people, and I am also one among them, who believe that after this first dose, complete schedule of vitamin D and calcium, give a parenteral vitamin D also, so that malabsorptions also have to be ruled out. So one oral dose of vitamin D, oral course, second a parenteral course, and then label them as resistant. Don't straight away label children to have resistant rickets. Okay. So how do we approach? Which is the most important investigation in resistant rickets? Phosphate, not calcium. So that's why don't send calcium alone without phosphorus. So phosphate, it could be low or high. Where is phosphate high? Only in CRF, right? Okay. So if phosphate is high, what will be asked the next step? Creatinine, because phosphate is high with rickets only in chronic renal failure. So if creatinine is high, we directly label them as chronic renal failure. If phosphate is low, then we ask for blood gas and urine pH. So if there is acidosis and urinary pH is 5.5, think of RTA. If phosphate is low, no acidosis, then ask for PTH. PTH is normal in which condition? With low phosphate, normal PTH. Hypophosphatemia. Okay. So go for phosphate excretion in the urine. If it is high, or if there is no reabsorption, think of hypophosphatemia. Are you following this? So low phosphate, now normal PTH, rickets. Where do we go? Low phosphate, normal PTH, rickets. So it is hypophosphatemia. Okay. There is high PTH, low calcium. It has to be calcium. All the conditions which cause hypocalcemia will be here. So here we have, it is a resistant rickets. So we have ruled out vitamin D deficiency. Yes or no? So it is either vitamin D dependent type 1 or vitamin D dependent type 2. Should I repeat this slide? Yeah? Yes? So which is the most important investigation in resistant rickets? Phosphorus. Phosphorus is high or phosphorus is low. Okay. If phosphate is normal, it is not rickets. Either phosphate is high or phosphate is low. If high phosphate, directly jump to kidney with rickets. If low phosphate, then we have bundle of problems. One, it could be renal tubular acidosis or not. If there is no acidosis, then ask for PTH. PTH is normal in hypophosphatemic rickets. Go for renal phosphate excretion, and if renal phosphate excretion is high and tubular reabsorption is low, label them as hypophosphatemic rickets. If PTH is high and calcium is low, we know this is calciopenic rickets. Either it could be vitamin D deficiency or vitamin D resistant. So we have labeled it as resistant. So we ask directly jump into two diagnoses, either vitamin D dependent type 1 or vitamin D dependent type 2. So how do we make diagnosis of vitamin D dependent type 1? In this high or normal 25 hydroxy vitamin D. Yes or no? Here there is deficiency of 125 hydroxylase enzyme deficiency. So conversion from 25 to 125 is altered. So 125 will be high, and 25 will be high and 125 will be low. So this is VDDR type 2, whereas both of them are high. The problem is at the receptor level. Why these will be high is because of the positive feedback. Because there is resistance at the receptor, no action happening. So what happens is positive feedback, it keeps on pushing these enzymes high and high. What are those enzymes? 25 hydroxylase enzyme and 125 dihydroxylase enzyme. They will be high. So this 25 hydroxylase enzyme will convert 25 hydroxy vitamin D into 125 hydroxy vitamin D. So both of them will be high. But this 125 is not able to act on the receptors. So both high, type 2. 25 high, 125 low, enzyme defect, type 1. Clear? Yeah. So what are the key message? Initial trial of calcium and vitamin D in all the cases, and sometimes if you suspect malabsorption, one, parental dose of IM. Okay. What are the pointers toward? Look, there are pointers towards refractory as I told you, that it could be polyuria, fractures, failure to thrive. Phosphorus is the key investigations, and once you label them as vitamin D, avoid repeated doses of vitamin D, because vitamin D is a drug and it is a lipid soluble vitamin, and there are multiple complications associated with this vitamin D, which is stored in the liver. Thank you. If there are any questions, I will be happy to answer about resistant rickets. All clear. We are running late. Thank you.
Thank you so much, sir. We have arranged tea and snacks, so kindly proceed for the tea break and we shall assemble in 10 minutes.
Thank you.
session. Anytime, any doubt, please.
You can disturb me in between.
Because we have to plot the growth charts here.
So, at outline of the presentation, it includes definition of short stature, types of growth charts, case scenarios,
Bone age and conclusion. So what is short stature? Any PGs can define short stature? Less than minus 2 SD is normal. More than 2 SD below the mean. See, this is a growth chart. All of you are aware of that. I am audible. In the growth chart, the upper one is the height. The child height is below here. The third centile corresponds to minus 2 SD roughly. So less than third centile. The 50th centile is a median. So more than 2 SD below the median. Less than minus 2 SD means it is above the third centile. So we should be more than 2 SD below the median for that age. We cannot plot the growth chart for the girl or boy exchange. We cannot exchange that. Age, sex, the rate of birth is important. The next is the population standards. We cannot plot our growth charts on a CDC. And we feel that they are short compared to them. So we use a reference population growth charts.
approximately 3% of children in any population will be short.
And half of them are physiological, the most common being familial short stature and the CDG, constitutional delay in growth and puberty.
Next, remaining will be
Pathological, among them even the endocrine causes are less common. So the PGs are using this infantometer and the stereometer.
till what age we use?
Why we use infantometer till 2 years? Any reason?
Because of the lumbar lordosis and also baby cannot stand.
And what is the difference between length and height? Which is more? How many? Roughly around 7 millimeter as per the WHO. That's why we have that small mark in the at 24 months in the growth charts. Small deviation. Length is more than the height. I'll show it in the growth charts.
So about 2 years we use a
Stereometer and 5 points has to be taken care. Heel, calf, buttocks, shoulder blade and the occiput. And the extra accessory things like the cap and the socks has to be taken out, and then you measure the height properly. Then only we can say the child is, well, like the height is accurate, and then you can correlate subsequently.
This is how we measure the
Length and the height. There are a lot of growth charts which have come into play. The WHO growth charts which came in 2005,
it is between 0 to 5 years.
CDC growth charts are there.
IAP Agarwal charts, Kadilkar charts 2009, revised IAP growth charts 2015.
And there are disease specific growth charts for Downs, Turners and all that. As per IAP, we are using WHO till 5 years. After that, we are using IAP. But if someone wants to correlate with their genetic potential, we can use the IAP growth charts from 2 years onwards. But otherwise, if you want to monitor the child, you can use WHO till we get the Indian specific growth charts for 0 to 5 years. These are the growth charts which have been provided with you in the
At the reception, so
these are WHO growth charts. The blue is for the boys and the pink is for the girls.
on the one side you have got a weight, head circumference and the length of the height. This was the deviation I was saying at the 24 months.
In the middle of the growth charts,
The length and the height, roughly around
7 millimeter, where there is a distraction towards the height.
So on the other side of the WHO growth charts, we have got
Weight for length or weight for height.
this is for the girls.
These are the IAP combined WHO and IAP growth charts.
The first 5 years is taken care by the WHO. Then the IAP are extended till the 18 years
For the Indian population, it's a reference.
For the same thing, on the other side we have got BMI charts. So going individually to each and every, this is the intergrowth charts.
People are using even Fenton growth for the newborn.
So we can use even intergrowth standards.
Because these are standards. Okay. Coming to the first topic on the weight parameters on the WHO growth charts.
Along the x-axis, it has been written the age in months.
Right? So in that, each month is represented at 1, 2, 3, 4. Some of the growth charts have been provided 2 lines in that. So every 15 days. You may have a division even for 1 week. So you have a division for 15 days. The babies will come to you follow up at 1.5 months, 2.5 and 3.5 months. So at 1.5, 2.5, so we can mark the growth charts. So it should be completed age in months or years.
So along the x-axis we have age in months, and along the y-axis 5, 10, 15, 20,
25 and one division is there. In all the growth charts, whatever is the method of printing, you should know how to divide the divisions in that.
because it will change in each and every page. Here the division is different, on the next page the division is different.
So you should know how to divide and plot approximately.
So in the growth chart,
The 50th centile means 0 ST, means the median, which says I am at the center. On either side, the things can change.
so up to 3rd percentile is normal, up to 97th percentile. So if someone weight, example for age of 25 months, if the weight is here, it is normal. If the weight is between these two, minus, okay, I'll come.
If the weight is between 3rd to 90th centile,
97th centile,
or minus 2 to plus 2 ST, it is normal for that age and sex. If it is between 3rd to 1st centile, the 1st centile is taken as minus 3 ST.
that is
Underweight. Less than that, it is severely underweight. This is the WHO classification of weight. Any doubt in this chart? Next is the microcephaly part. That
same parameters are there,
50th centile, 3rd centile, and the 97th centile. Actually speaking, we don't use centile, we use standard deviation, plus or minus to standard deviation. What is the difference between a percentile or a standard deviation score? SDS. Percentile says the ranking, you are at this rank. But how far you are from the mean? 3rd percentile says you are at minus 2 SD. Less than 3rd percent, it can be anything. If I am at minus 3, minus 4, minus 5, that says my ranking, how far I am from the center, median. 3rd centile says you are at minus 2. Less than 3rd centile, I don't know where I am. I may be at minus 3, minus 4, minus 5. So when you are objectively monitoring the child, the SD score is more important. Now today the baby is at minus 2.5. After 3 months, you see it is minus 2.3. It is better or worse? Better. After 3 months, it is minus 2. So it is showing there is an improvement. So the standard deviation scores are objectively you can assess, but everything will say less than 3rd centile. We cannot say. So the trend, for the knowing the trend, we should use a standard deviation score.
For the same parameters, again the 50th centile 0. The one in the parenthesis is standard deviation. Outside is the number. This is 3rd centile minus 2 SD, 1st centile minus 3 SD. Above is the 97th centile.
That is a plus 2 SD.
This is normal.
If it is between 1st to 3rd, it is stunting. Less than 1 percentile is severe stunting. So this is length for age, that or height for age. That was weight for age. You are, for your age, you are short. For your age, you are underweight. That's it. But are you able to maintain your weight for height? Means even though you are short, you are maintaining that much amount of body mass. That is the next part. Weight for length or the weight for height. This is on the other side of the growth charts. This one will be missed by many of the people.
Along the x-axis,
If you can see, you have got length or height in centimeters. The divisions has to be understood when you see the growth charts. The divisions are like 45, 46, 47, and you will get some value of 45.5.
at that value you have to go up.
Where is the weight of the child?
For example, if you can get 75 centimeter, the weight is 5 kg.
Where it comes? At the length of 75 centimeters.
If you get a weight of 5 kg, where it comes? Yes, less than.
Minus 3 SD.
If it is somewhere around 7 kg or 8.5,
At 75. Minus 2 to minus 3.
if it's something like 10 kg, maybe normal.
75 centimeter is the length of a 1 year, roughly around 1 year old child. If you are 5 kg at that age, you are wasted. So, this is normal again. from 1 to 3rd centile, it is wasting, which we call in WHO term as moderate acute malnutrition. Weight for length or weight for height, like between -2 to -3 SD is wasting. Less than that is severe wasting. So when we ask the definition of SAM, it is a weight for length or the weight for the height, not the age. Because you are not able to maintain that much amount of weight for that height. That is SAM. If it is more than 99 centile plus 3, we take it as obesity. But usually after 2 years, BMI tables are also available to count for the obesity. Okay. Coming to the IAP growth charts now. The IAP growth charts has 2 parameters, the weight and the height. So along the x-axis, the growth charts has shown age in years. First of all, the date and the name of the birth, the name of the child and the date of the birth is very important, because my pages write 11 years means 11 years only. 11 years 6 months is 11 years. 11 years 9 months is 11 years. When they come to 12 years, they plot. I ask them, do they grow only at birthdays? They don't grow during birth. They grow throughout the year. So height, perceptible change in the height can be made only with a gap of 3 months. Weight can change, but the height, to know there's a perceptible change, we should do it every 3 monthly monitoring. So 11 year 3 months, 11 year 6 months, 11 year 9 months and 12 years. So the date and name of birth has to be mentioned on the top of the growth charts. So on the x-axis, you have been provided age in years. The darker lines are years, lighter than that it is 6 months, lighter than it is 1 month. There is 12 divisions. Some growth charts provide 10 divisions. That's a decimal age is very difficult to understand. So the IFP growth charts has given 12 divisions. So child is 11 years 7 months, 11 year 10 months. You can plot directly on that. So there are 12 divisions on that. So the individual divisions are months, the darker are the years, lighter than that it is 6 months. Similarly in the height, there are same parameters are used. Why there are 7 lines here, not in the WHO growth charts? How many lines are? 7 lines, right? So the middle one is 50th centile, the last one are 3rd and 97. Then you have got 10 down, 90 above, 25 down, 75. So there are 7 lines in that. Why is the requirement of 7 lines? The importance lies here. The child comes to me at this point for the short lecture. I don't know when the child stopped growing. For that, I check back the records of the person who has measured the height. Most of the time we get only weight. We don't get height. When we look at the one of the height, it was here. Another was here. Another was here. The child has crossed 2 major lines. If the child is crossing 2 major lines, even though it has not come to me at this point, I will really bother at this point only. Because if I start treatment for thyroid or something at this point, the final height I cannot assure them. If I start treatment here, and I can assure them the final height. So identification of the disease earlier will help you better. That is why growth charts will tell us the diagnosis rather than investigations. This is clear. The lines crossing of 2 major lines. Not only the height less than 3rd centile or more than 2 SD below the median, even the crossing of 2 major centile. Example, here the child was 116.